I'm delighted to introduce our speaker today, Dr. Guido Lancman of Princess Margaret Cancer Center and the Myeloma Clinic. Dr. Lancman is going to be describing to us what myeloma is, what the current treatments consist of, and also quite a bit about some of the new treatments that are on their way. And you may know that there are many new treatments. This is the golden age of myeloma treatments. There is continuous change and better treatments. There's an annual ASH conference, which all of the hematology oncologists attend every year, and they learn about these new treatments. And Dr. Lancman is going to share some of that information for us. He's known to many of us here, and certainly to me, because he's my oncologist as well. And his clear and direct approach to patients, that while showing compassion and understanding, is very effective when combined with his deep technical knowledge, which I think you'll appreciate. Dr. Lancman is also adjunct assistant professor in the Department of Medicine at the University of Toronto. And he was recruited from the Icahn School of Medicine at Mount Sinai, New York City, and has brought much to the myeloma practice at Princess Margaret. To prepare for this talk, I asked Dr. Lancman for his CV, and it turns out that it's 13 pages long. I'm very impressed by his deep clinical research experience, his contribution to publications, his abstracts, and invited presentations and peer review works. And so how does one so young, or who looks so young, accomplish so much? Please join me in welcoming Dr. Lancman to our support group.
So yeah, thanks for a very kind introduction. Sorry I'm late, although I don't think it's the first time you've seen a doctor be late for something. So, and I just want to acknowledge Dave McMullen. So he's actually the one who invited me to give this talk originally last year. Unfortunately, I couldn't make it. I was on leave, but being the planner that he was, he invited me a year ahead of time. So here I am, and obviously, Dave has had a huge impact on this whole community, so I just wanted to acknowledge him. So today we're going to discuss a few topics. What exactly is multiple myeloma? How do we treat myeloma now in 2025? And then what's coming next, and how can we get these cutting-edge treatments to Canadians here? Treating myeloma is a very complex topic. I'm not going to be able to cover all of it. It takes years to learn how to treat myeloma well, but we'll try to cover at least some of the basics. So first, what is multiple myeloma? In all the long bones of the body, the larger bones, we have bone marrow inside. And these are basically the factory where we make all the blood cells. So this is white cells, red cells, and platelets. And we have a type of white cell, immune cell, called a plasma cell. And normally what it does, you can see in the blue, is it makes antibodies. And these are helpful. Like when you get an infection, you make antibodies to fight it off. When you get a vaccine, you make antibodies to protect you against future infections. And what happens in myeloma is these plasma cells become cancerous. They start dividing uncontrollably, and they start making a lot of the same antibody over and over again. It's usually not a useful antibody, but that's kind of what happens with myeloma. So it's basically these immune cells that just go haywire and start making a lot of unnecessary protein. And what are the symptoms of myeloma? We refer to this as CRAB, C-R-A-B, and that's high levels of calcium in the blood because of the damage that the myeloma cells cause to the bones within the bone marrow. Decreased kidney function, which usually happens as a result of too much protein being made and clogging up the kidneys. Anemia happens, or low red blood cells, happens because the myeloma cells crowd out the normal production of red blood cells. Then bone damage, because myeloma cells secrete chemicals which damage the nearby bone and can cause little breaks, and sometimes full fractures of the bones. So what are the myeloma proteins? And I know this is a topic, talking to my patients, that confuses people even 10 years down the line from their diagnosis. So myeloma protein is basically an antibody. An antibody is this Y-shaped thing, and it has two components. The blue part is called the heavy chain, and the orange part is called the light chain. And the heavy chains can be one of five: IgG, IgA, IgM, IgD, and IgE. And the light chains can be either kappa or lambda. So when your myeloma cells are making the same protein over and over, this is basically what you're making, and you can make any combination of heavy and light chains. You can make just the heavy chain, just the light chain, both, or in some cases neither, which is, that's when you can't really pick up the proteins in the blood as well. So how do we diagnose it and track it using these proteins and what we know about myeloma? So first is a procedure most of you have probably had, which is a bone marrow biopsy, to look for the actual plasma cells in the bone marrow, and we can get a lot of information from that. The next is imaging, which we look at the whole body to see what damage myeloma has caused to the bones, and if there's masses anywhere, things like that. And then we do a lot of blood and urine tests. This is where I think a lot of confusion can arise. So just go through quickly the different types of blood tests we do for myeloma, and hopefully this is helpful to you for your future appointments. Now everyone's getting all the blood tests on their phone, and they come in and they already know all the results. So it's good to at least try to understand what each of these means. So the M-spike only measures the amount of abnormal heavy chain. So it's only going to measure abnormal myeloma protein that's IgG, IgA, IgM, IgD, or IgE. It's not going to pick up light chains, so it just picks up the abnormal heavy chain component. We also check the total amount of immunoglobulins, the Ig levels, and this will include normal and abnormal. It doesn't distinguish. So if you have like an IgG myeloma, your IgG might be high, but it's going to be partially normal IgG, which all of us have, and part of it will be the myeloma IgG. So that's just a total amount. We have the free light chain test, which only checks for the light chain part of the antibody, and that's kappa or lambda. And then we sometimes ask you guys to bring in big jugs of urine that you collect over a full day. And this test is useful to pick up light chains in particular. So which tests are relevant to you is going to depend on what your myeloma makes. So if you have, for example, an IgG kappa myeloma, you have a IgG heavy chain and a kappa light chain. So we can look at the M protein, which is the abnormal amount of IgG. We can look at the total IgG. We can look at the kappa-free light chains, and we can look at the urine. If you have, for example, just a lambda myeloma, now we only look at the free light chains in the urine. You're never going to have an M spike. You're not going to have abnormally high immunoglobulins either in that case. Yes?
Yeah. In Princess Margaret, when you get back to blood tests, often the M spike says undetermined. Does that mean it's too small to determine, so it's good news, or does it mean something else?
Yeah, that's a good question. So it can mean a lot of things. So M-spike is basically looking at the total amount. So they try to measure how much abnormal protein there is. Sometimes there's a tiny little spike. It's not enough to measure, but they see something there. That could mean a lot of things. It could be from the myeloma, but it could also be from some of the drugs that are actually, the way they're constructed is actually like an antibody, so it can get picked up by these tests. And then sometimes when you have an infection, you can have an antibody response, or like a vaccine, and you can have a tiny little spike as well. So it's in medicine, there's no easy answers, so it's not a definitive that you have myeloma or don't have myeloma. It could mean a lot of things. Yeah?
Where does the ratio come in when they say don't worry about the actual IgG and IgA numbers per se? You look at the ratio, and if it's 1.65 or less, you're good.
Yeah, so the ratio refers to the ratio of kappa to lambda. So in people who don't have myeloma, the ratio is close to 1 to 1. When you have myeloma, the ratio gets abnormal. That's usually more useful for diagnosis to see if something's off with the ratio. It's a very nuanced approach, but you have to consider everything in context. Usually, once you already know you have myeloma, you just track the one that you have, like kappa or lambda, and see how much it goes up. That said, sometimes they can both go up at the same time, and that's the ratio itself can be a little bit helpful there. For example, if your kidneys stop working quite as well, you don't pee out as much of the light chain, so they're both going to go up in the blood. In that case, it doesn't mean your myeloma is getting worse, it just means you're slower at getting rid of the proteins. Yeah, it's tough. There's no easy answer there either about the ratio, but I hope that helps a little bit. Okay. Yeah?
I'm under the impression, maybe wrongly, that multiple myeloma is a difficult disease to diagnose from a doctor's standpoint, just if you're a run-of-the-mill patient, so to speak. I'm just curious, the impression I have also is that the bone marrow biopsy is probably the gold standard to determine you do have that. Are there any other tests that are very, I don't know, up on that level, so to speak?
The bone marrow is the gold standard, for sure. Yeah, usually we see patients once they're already diagnosed, but the way a family doctor might pick it up is usually like anemia, like your blood count is lower than it should be for someone your age. Sometimes your kidneys are not working that well, and that leads to a whole workup, a bunch of blood tests, and then they might check the light chain, something like that, and they see an abnormality, and then you have to check in the bone marrow to make sure it's actually myeloma. And sometimes people get like imaging, they come in for a pneumonia, for example, they'll get a CT scan, and then they see abnormal sort of breaks in the bone, and that leads to further workup as well, that there might be something abnormal there. But ultimately, you do need a bone marrow to really confirm. Okay, so how do we treat myeloma? First, there's some basic principles. First, obviously, we want to kill the myeloma cells to prevent further damage, like the crab symptoms that we talked about. And I'll spend pretty much the rest of this time talking about how we do that. There's some other things that are important as well. We want to alleviate symptoms, so pain medications are very important if someone has a fracture or has a significant bone pain. We want to treat fractures, so that can be a big orthopedic surgery if you break like your arm or your leg, for example. Or kyphoplasty or vertebroplasty, which is usually when you break one of the bones in your spine. And it's a pretty minimally invasive procedure, and basically they go in with a needle, use a balloon to blow it up back to its normal size, and then fill it with cement. And that way it doesn't collapse and cause pain. It's a usually pretty effective procedure. Some of you may have had it yourself. And then transfusions are important. Usually in the beginning if someone's very anemic, for example, just to make them feel better. Bone health is extremely important in myeloma, so we have very good bone strengthening medications. Usually at diagnosis, you've had probably the myeloma for a long time, and if you look back, almost 100% of people have actually had the abnormal protein for 10 years or longer, so it's a very slow process, but it's been there a long time and can lead to some damage at diagnosis. A lot of you may have taken drugs like Zometa infusions, and these help to strengthen the bones from the initial damage. Calcium and vitamin D is important as well, just for the bones. We have bone density tests that can help diagnose, for example, osteoporosis, which is also a condition that's treated with drugs like Zometa. And you want to avoid excess stress on the bones, so some patients participate in extreme sports, and I have to try to convince them not to do that. But everyone does what they want. But usually don't want to lift too much weight because that does put a lot of pressure on the spine, and that can lead to fractures as well. We want to avoid or prevent infections because this is one of the main causes of hospitalization and death among myeloma patients. So you want to make sure up to date on all your vaccinations. Take whatever antibiotics or antivirals you're prescribed based on whatever treatment regimen you're getting. You want to practice good hygiene always, washing your hands, using masks if you're in a crowded place or people are sick around you. And you want to get evaluated quickly for viruses like COVID and the flu, which maybe the flu didn't used to be a huge deal, but now that you have myeloma, it can affect you a little bit more and sometimes put people in the hospital as well. And then we want to protect the kidneys because they're very sensitive to damage if you have a lot of protein, for example. So we want to avoid a class of drugs called NSAIDs, which includes everything that's like ibuprofen, Advil, Motrin, Aleve, things like that. We really don't want to use that at all if we can. You always want to stay well hydrated. And this is something more on our side, but we try to avoid CT scans that have IV contrast because these can affect the kidneys as well. Okay, so myeloma has changed a lot in the last 25 years, very much for the better. These are all the drugs available 25 years ago to treat multiple myeloma. And this is what we have now. So we have a lot of different classes of drugs. We have a lot of drugs within each class. And then we have the very exciting new category of treatments, which are the immunotherapies, highlighted in green here. And it's a little bit hard to read, but we're going to go through a lot of them as well. Mathematically, the possibilities for how you're going to be treated for your myeloma are really endless. When you think about it, we use drugs sometimes alone or in combinations with 1, 2, or even 3 other drugs. Each combination is what we call a line of therapy, and patients will get many lines of therapy throughout their course, sometimes even more than 10. New regimens are approved all the time. Sometimes these are new combinations of old drugs, sometimes they're just brand new drugs. We have clinical trials that offer treatments that are not yet approved as well. And luckily, because we're not in the year 2000 anymore, most patients are going to be living usually 10 plus years. I mean, obviously not everyone, but this is what we're hoping for going forward, and hopefully much longer than that. And in the time that you have myeloma over, let's say, a decade, a lot can change. And no two patients are the same, and no two myelomas are the same. I think it's important to emphasize every myeloma is different. Some behave very aggressively, some are very indolent or slow growing, and every single myeloma is going to behave differently. So you can't compare to your neighbor, to your friend. Everyone goes through a different journey. And so no two treatment sequences are really the same. So it's going to be hard to find anyone that had the exact same treatments as you all the way through. And therefore, I just want to emphasize there's no such thing as an optimal or correct sequence for myeloma treatment. Everyone's going to get treated probably a little bit differently. This is going to be extremely hard to read. But these are basically all the treatments and regimens that are funded for myeloma. And in this first column, you can't see my mouse. The first column is the first-line treatment, so what patients get when they're newly diagnosed. Then we have second line, third line, fourth line, and you can see at each stage you actually have many, many different options. And on top of what's funded, we have clinical trials, which are experimental treatments that are not yet funded. We have access programs sometimes where we can get medications that are not funded but we think might be helpful. And then for those who have private insurance, you're sometimes able to get treatments that are, for example, Health Canada approved, but not yet actually funded publicly. And so myeloma is really not an algorithm. It's really more of a chess match, and it gets really complex when you factor in all the different possibilities. And like I showed 25 years ago, we didn't stand a chance against myeloma. Now we have a lot more good pieces, combinations, strategies, and it's becoming more of a fair match, and hopefully in the future it'll be an easy win. But right now it is very complex, and I'll sort of try to talk through some of the treatments, but it's going to be impossible to truly cover all of it. I am going to show some curves that are going to look like this, and this is called a Kaplan-Meier curve, or a survival curve. And a lot of the clinical trials use something called PFS, which some of you may be familiar with. It's a progression-free survival. And basically what it means in a very simplistic way is patients who are alive and in remission. So we don't want you to be alive with myeloma coming back, and we don't want you to be in remission but dying of something else. So we want people to be alive and in remission from the myeloma. And basically, at the start of a treatment, everyone starts here at the top, so at 1 or 100%, and every time someone either dies or their myeloma comes back, the curve drops a little bit. And once it gets to 0, it means that no patients are alive and in remission by that time point. So we're going to see a lot of studies that show this, so just to so everyone understands what it is. So the first thing we have to think about when someone's diagnosed is, should we do a transplant or not? And that's really sort of the first fork in the road. And the things we use to consider whether someone can get a transplant, because it is a pretty intense procedure. Many of you have had it as well. We typically look for a younger age. There's no strict age cutoff, but usually under 70. That said, if someone's in pretty good shape, it can go up to almost 75, although usually not that high. We look at other medical problems that might cause issues during the transplant, so we want to make sure patients can survive the transplant and not be left with lasting damage. And we want to make sure someone's in good shape physically, so not just the age, but thinking about how physically fit someone is. And of course, how aggressive the myeloma is also plays a role in deciding that. And of course, the patients have a preference as well, so it's a discussion. But obviously, how far away you are from the transplant center, what your support network looks like for the recovery period, which can be up to 3 months, sometimes longer. And also preference, some people just don't want to do something more intense and risky in the beginning. So we'll talk about, for newly diagnosed, what it looks like if you get a transplant, what it looks like if you don't get a transplant, then we'll talk about some other therapies. So if you do get a transplant, most patients will get either Cy/Bor-D combination, which is cyclophosphamide, bortezomib, and dexamethasone, or VRD, which is bortezomib or Velcade, lenalidomide, and dexamethasone. Then you get the transplant, which is the ASCT, and then you go on a maintenance pill, which is lenalidomide or Revlimid, and that's pretty standard for all patients. Some who have insurance can actually get another drug added in, and we'll talk about that as well. So the idea of doing transplant versus no transplant comes from this clinical trial. So patients were either given this VRD combination for about 6 months and then just put on maintenance pill, or they were given the VRD for a few months, the transplant, and then put on the same maintenance pill. And you can see the more yellow gold line is the transplant, and the other line is without transplant. So you can see if you do the transplant, your median, so half of patients get more, half of patients get less, is about 5.5 years of being alive and in remission. And with the transplant, a good chunk of patients, 20–30%, are going 7+ years out without needing any other myeloma treatment, so doing quite well. And if you do only the VRD, for example, without a transplant, the median's about 4 years of remission, and then you have to go on to a new treatment. Again, these are medians, so there's a distribution. Some patients are very unlucky, and myeloma comes back within the first year. But again, some patients go on even more than 10 years after their transplant. So there's a recent clinical trial that looked at basically the same thing, but adding in a new drug, daratumumab, which many of you have probably also gotten. And this basically just compared adding daratumumab to the VRD versus just the VRD. And then everyone gets transplant. And then for the maintenance part, instead of just being on the maintenance pill, patients were given daratumumab for at least a couple of years in addition to the Revlimid. And what this showed was a pretty significant advantage for getting the daratumumab. You can see at the 4-year mark, 84% of patients were still alive and in remission, which is incredible. And if you did not get the daratumumab, that number was about 17% lower, about 67%. So as I was saying, the addition of this daratumumab, which is an antibody therapy, is extremely effective. And this regimen is now Health Canada approved. It's not funded yet, but we're hoping that hopefully soon, the company will provide a sort of access program so all patients can get this drug in addition to the VRD. And as you can see, it really does improve outcomes quite a bit with really minimal added risk or side effects. So this is going to become the new standard treatment, and hopefully we can get it soon. Yeah.
Is there research on people who have been on the maintenance of Rev and then they have a relapse, but throwing the DARA out, like starting that and then level protection or no?
Starting the DARA after someone's been on Revlimid for a number of years, you mean?
Yeah, they haven't done the DARA wasn't introduced in induction, like the thyroid and the stem cell, and then you had mentioned that depending if you have drug coverage, that instead of just going on Rev as a maintenance, that you add DARA to that. Is that correct?
Yeah, so there is a clinical trial that looked at this exact question. So it's it's daratumumab plus lenalidomide for only maintenance, not for the first part, versus just len maintenance. And again, there's a pretty significant benefit to adding the daratumumab. So even if you can only add it after the transplant, there's still some benefit. Actually, we'll talk about this next trial because it's going to answer a lot of the questions that you're asking. Yeah.
Regarding the daratumumab, do you have any idea when that might be approved at the provincial level? You said it's approved at the federal level, but at the provincial level, there's no dragging the feet.
I'm no expert. I've been in Canada for 2.5 years, and what I've learned is that things move very slowly. However, because patients are going to be on these therapies for a long time, especially for the maintenance, just at least a couple years, the companies are very interested in getting patients on these treatments. So usually what they do in these cases is provide the drug for free until it's actually funded by the government, and then once that happens, everyone transitions over to the government funding. So I don't know exactly when a program like that's going to become available, but it's hopefully soon. So this other trial is going to help answer some of the questions that you asked, which is, do we need it in the beginning or maintenance or both? And the other trial is not going to answer that question because patients got daratumumab the entire time. In this trial, which is a German trial, isatuximab, which is very similar to daratumumab, works in exactly the same way. Patients are going to get either isatuximab VRD versus VRD, and then get transplant, and then the patients will be randomized again after that to get isatuximab and Revlimid or just Revlimid. So there's basically going to be 4 different groups in the end: patients who got isatuximab the whole way through, people only got it in the beginning, only got it in maintenance, or didn't get it at all. And although we don't have all of the results of this trial, we just need a bit longer follow-up. That's going to help answer a lot of those questions about the maintenance part. So far from the trial, this is just from the first randomization, so patients who got isatuximab in the beginning versus not getting it, as you can see, did better. The follow-up is still a little bit short, and the difference might not be quite as big as the other trial because of the second randomization, and some patients might actually catch up by getting it during the maintenance only. So those are the major changes that are coming for transplant-eligible myeloma. So patients who are not going to get transplants, so it's someone who might be like over 70, maybe not in great shape, certainly over 75, we won't consider a transplant. Most patients are going to be on DRD, which is DARA, lenalidomide, and Dex. That's sort of the standard now. There are other options, of course. If someone's not able or willing to come in for the injections and they just want pills, you can just get Revlimid and Dex. And if you have, for example, issues with your kidneys, you might start off with a different regimen like Cyborg-D, which is easier for the kidneys, and then you might switch over to DRD if the kidneys recover, or something like that. And the standard DRD treatment is based on this clinical trial, which is MAIA, which compared DRD versus just RD without the daratumumab. And you can see the median PFS, so the point at which half of patients had not progressed or died, was about 5 years, a little bit over 5 years. And of course, some patients going longer than that as well. whereas just getting the RD was about 3 years. So again, adding the DARA gets an extra couple of years up front, and some patients actually stay on for quite a long time. But the quadruplet therapies are coming for, for the non-transplant patients as well. Yes, go ahead.
The question. So when we're talking about all these different results, you're talking about first transplant or maybe even second transplant. Is that applicable to both transplants?
No, this is for first transplant only. Second transplant is a totally separate topic. That's also very complicated, but we can discuss more if you want later. This is just for getting one transplant in the beginning. Sorry?
Who was that a picture of? That's what I'm looking
It's from Google, I don't know. I have no idea. So we have a few trials actually looking at these quadruplet therapies for patients who are not going to get transplant. And the long story short is that they all show benefit with really minimal added toxicity. So this is going to be the future for basically all patients. But we have a few trials here. We have Cepheus trial, which is DARA VRD versus VRD without the DARA. And you can see, again, a large separation at the 4.5-year mark. Still almost 70% of patients in remission with the DARA VRD. We have another trial called IMROZ, which is isatuximab VRD. Again, it's a very similar drug versus VRD. And again, at 5 years, there's already a huge advantage for having 4 drugs instead of 3. These two trials are, because they were designed a long time ago, the control arm, or the VRD, is not what we use anymore. As I mentioned, we use the DRD combination. So it's not, let's say, a fair comparison to what we're using now. But there is a trial which was ISA VRD versus ISA RD, which is very similar to DRD. And this is really what a quadruplet would look like in Canada, which is adding the Velcade on top of the DRD. And this trial is still very early to say, but on the right, we haven't talked about MRD negativity, but it's basically a sign of having a very deep response that usually correlates with prolonged remissions. And the MRD negativity rates, which is what we want, is more than 2 times higher with the 4 drugs versus the 3. So likely there's going to be a pretty significant benefit for the 4 drugs. So, will every non-transplant patient need 4 drugs? Some patients might be a little bit older, maybe more frail, maybe someone in their mid-late 80s. So the answer is probably not every single person's going to need 4 drugs, but it's definitely nice to have this option for a lot of reasons. Again, most patients will do very well on the DRD, so if you're already on it, it's perfectly fine. Stay on it, especially if you're doing well. You're probably going to do pretty well long term. But Velcade's a very easy drug to add in. It's been around a long time, more than 20 years. So it's not hard to add it to an existing regimen. The side effects tend to be pretty manageable, some neuropathy, some GI side effects, some low platelets. But it's not given forever. It's only for 6 to 12 months in these studies and still showing a very significant benefit. And of course, the doses can be adjusted. I personally would rather give 4 drugs at lower doses and have them all kill the myeloma in different ways than give 3 drugs at the higher doses, which is actually very hard to do in this sort of transplant-ineligible population. Because patients might be in their 80s and they're not going to tolerate 25 milligrams of lenalidomide, for example. So instead of giving the full core press on the 3 drugs, we can go down on the doses and give 4 drugs instead and get probably more benefit. And I would say patients who have high risk or aggressive disease who may not do as well with just the DRD should definitely be getting the quads in the future. You already asked the question of when it's going to be available for the transplant patients. So when is this going to be available? Actually, we just learned the company that makes isatuximab has already opened a program. So they're providing the drug for free until it gets funded. So now all the transplant-ineligible patients should be able to get the 4 drugs available to them. Any more questions on the newly diagnosed myeloma? Yep.
Aggressive or not aggressive, do they respond to the treatment the same way or different?
Yeah, so high-risk myeloma, at least until now, responds less well to pretty much all of the older treatments that we have. And old is relative in myeloma, old meaning a few years ago. The immunotherapies tend to do a little bit better in that respect. There's not as big of a gap between how the high-risk and standard risk patients do. But with these regimens like DRD or Dara-VRD, transplant, the high-risk patients, they do worse than the standard risk patients no matter what treatment they get. That said, that, like, for example, a high-risk patient will still do better with 4 drugs versus 3, but overall the results are going to be not as good as the standard risk. Okay, so what do we do when the myeloma comes back? So in most cases, myeloma does come back. It's very hard to get rid of, and that's because the plasma cells that the myeloma comes from normally live for an extremely long time, which is great because, for example, you get measles in your childhood, you have plasma cells that stay with you the rest of your life, making measles antibody, for example, to protect you against infection. So by design, they're very hardy cells. They live for an extremely long time and can be very hard to completely eradicate. So typically, myeloma does come back, hopefully after a number of years. And when it does come back, there's a lot of different things we have to consider when we think about what next treatment to give. And that's patient factors, disease factors, and treatment factors. And the list is quite extensive. I'll just go through a few of them. So for the patient side, we want to think about how old someone is, how physically strong they are, what they can tolerate. Lifestyle preferences do play a role, like how often someone has to come to the cancer center to get treatment, how much support they have from caregivers to take them to all the appointments. And then there's medical issues like how your kidneys are working. Do you have heart disease, diabetes, low blood counts? Do you have neuropathy? All these are going to affect the treatment choice. And then we look at the disease. So we look at things like high risk or standard risk. We see how fast the myeloma is growing, how much of it there is. That determines how aggressive you need to be with the myeloma when it does come back. And then treatment depends a lot on what someone has had before is going to affect your choice, how they responded to what they had before, to certain classes of medications, what toxicities we might expect from the treatments and compare that to how the patient's already doing. And then, of course, access is a huge factor as well, especially here in Canada. So again, myeloma is not an algorithm, but if you were to just follow the basic algorithm of if you got a transplant and lenalidomide maintenance, what are your next options? And usually that's either DVD, which is Dara, Velcade, and Dex, or ESA, again, isatuximab, with carfilzomib and dexamethasone. That's probably the most potent one that we have. Carfilzomib is basically like a stronger version of the Velcade. And of course, again, we have clinical trials in all of these scenarios, as well as access programs and insurance. And for someone who didn't get a transplant and got DRD, their next best step might be either carfilzomib and dexamethasone, or a combination of Velcade, dexamethasone, and another medication we haven't talked about yet, which is selinexor. So that's the basic algorithm, but I want to, yeah.
If you had Dara before the transplant and you have a relapse, can you have Dara again?
So you had Dara before the transplant, and then you're not, you have a relapse while you're not on the Dara, you're saying, in the future? Yeah, so the criteria for getting another CD38 antibody, which is Dara or ESA, is that you're not refractory. So if the relapse didn't happen while you're on the treatment, then you can get it again. It's not like you just get it once and no matter what happens, you can never get it again. Sorry, I think I zoomed in on this page, but while someone fixes this, I'll take your question.
What's the thinking about doing this stepwise, all these treatments, sort of stepping up the amount of drugs that you take, the variety of them versus going right to the big gun at the end?
Yeah, it's a very important question. There's no clear answer. I can really only give you my opinion. And it might be helpful to see some of the results and talk about what the benefits are and what the potential risks are as well. And there's not really agreement in the myeloma community. Nothing's cut and dry. So there's going to be a lot of different opinions. My opinion is CAR T is extremely effective no matter when you use it. There's other treatments that might be less effective if you use them later on. So I don't necessarily think you have to use a big gun like CAR T for like a first relapse. You may want to do that if someone has like more aggressive disease, more high-risk disease. They might do a little bit better with the CAR T, but it's not really like a clear answer. I think it's going to vary a lot on situation. It's going to vary a lot on access as well. We still don't have CAR T funded. And when it is funded, it's going to be funded for pretty much all patients who have relapsed. So, because they applied for 4+, fourth line plus, and then 1 to 3 prior lines, and they're going to get funded for everything. So basically, anyone who's had 1 prior treatment will be able to get CAR T in theory. But CAR T is very complex to administer. Right now, at Princess Margaret, we're the only place in the whole GTA, which is several million people that can do CAR T. There's a lot of CAR Ts already happening for lymphoma, for example, that are already funded. So there's going to be some limits on the capacity. And my guess is probably patients who are a little more out of options, let's say, are probably going to be prioritized to get a CAR T as opposed to someone who's, in their first relapse and they have 30 different options. But yeah, it's a good question.
Yeah, if you're on your first relapse, if you go into your first relapse and you've had the stem cell, and then you go into a relapse, is the quad treatment? Are there trials about the quad treatment as compared to the triplet? Because you said that they're not doing the quad after a relapse.
So there are a few studies looking at 4 versus 3 drugs. Actually, one of them was like a pan-Canadian study. It's looking at dara, pomalidomide, and cyclophosphamide with dex versus just dara, cyclophosphamide, and dex. Probably using 4 drugs is helpful in relapse. Not everyone needs it. Depends on how aggressive your myeloma is and what the relapse looks like. But there aren't any quads that are funded for relapse in any setting. And I don't think we currently have any clinical trials, for example, at Princess Margaret looking at that. But the need to have, for example, 4 drugs at once is decreasing a little bit because of how strong the immunotherapies are. I'll show that a little bit. So now we're going to talk about some exciting new therapies. We'll try to go a little fast. You can ask as many questions as you want, but there's a lot of information to go through, which is a good thing because it means we have a lot to talk about. So let's get started. So we've already had a question about CAR T before I even started this section, so obviously on people's minds. So what is CAR T therapy, first of all, because it's a little confusing. It's very different to most therapies that we know about. So first step, we collect your blood. We isolate a type of white blood cell called a T cell. It gets sent to a lab. It gets reprogrammed to express this protein on the surface that can identify and attack myeloma cells. They're grown in the lab, so we have a nice large quantity of them. And this process can take about 6 to 8 weeks. And once that's completed, we take all the new T cells and infuse them back into the patient. And the T cells all can identify the myeloma and ideally kill as much of the myeloma as possible. So we have one CAR T product in Canada that's been approved and probably will be funded sometime this year, as I mentioned, for any time after the first relapse. And that's based on this CARTITUDE-1 study. I won't go through the design, but basically all the patients got this CAR T product. You can see of the patients who got the product, 98% of them responded, so as close to 100% as you can get. Of course, there were about 10 or 15 patients who entered the trial, but for one reason or another weren't actually able to get the CAR T. And that's going to be an issue all the way down the line, because it does take 6 to 8 weeks to make, and a lot of things can happen in those 6 to 8 weeks that might preclude someone from actually getting the infusion back of their CAR T. But if you're able to get it, it works, at least this product, almost all the time. And then, again, sorry, these are a little bit small, but on the top is the PFS, which we've been talking about. And the median's about 3 years. So it's just one infusion, no further myeloma treatment. And the remissions last on average about 3 years. And the overall survival is also pretty good, which means it's not hurting people either. That said, CAR T is a very complex therapy. As I mentioned, not everyone's going to be able to get it, just for capacity and other issues. But there are some side effects that can happen. Short term, what happens is when the CAR T cells are infused back into the patient, they all go and kill the myeloma at the same time. And that can cause a really high amount of inflammation, as all the dead cells release chemicals and the immune cells release chemicals to kill the myeloma cells. There's basically a huge inflammatory reaction that happens in the beginning. So most people need to be hospitalized for the first couple of weeks so that you can be monitored closely and treated promptly for it. And that's called cytokine release syndrome. And along with that comes something called neurotoxicity, or ICANS, which is basically the same inflammation causing some neurologic symptoms, which I'll talk about briefly. And there are some long-term side effects of CAR T as well, which can include low blood counts. It can stay low for a long time, sometimes more than 6 months. Infections, second cancers have been reported, and long-term neurologic toxicity as well. So first, cytokine release syndrome. So this is when all the inflammation happens in the beginning. Usually you're hospitalized. The main thing you get is fever, and you can also get things like low blood pressure, low oxygen, sometimes needing some temporary oxygen. And this lists basically everything that can go wrong with your body, which is a lot, but basically it's just a matter of inflammation and trying to get that under control. As I mentioned, you can also get neurologic symptoms in this early stage, in the first couple of weeks. Usually it's like a headache, tremor, getting a little bit confused, sometimes not be able to remember certain words, hallucinations, and at the worst, coma and seizures, which can happen. Patients do end up in the ICU sometimes. Not as much with the myeloma CAR T, usually more with the lymphoma CAR T, which are different products. But these are usually temporary. I mean, they're pretty much always temporary, but you have to treat them promptly. And then they do reverse. So if you couldn't remember words before, you get treated, and then you can remember your words again. Long term, I talked about some potential side effects. So low blood counts, anywhere from 10 to 26% of patients will have low counts, even at the 2-month mark after the CAR T, and sometimes this can persist for a long time. Infections are an issue because the CAR Ts are killing all the myeloma cells, but also all the normal plasma cells that we talked about, which are very important for fighting infections. So about 20% of patients get severe infections where they have to be hospitalized. Second cancers, at least in this study, were reported in about 21%. They're about half skin cancers and half other cancers, usually blood-related. And there's rare but sometimes long-term neurologic toxicity, which is different than the initial toxicity you get during the first 2 weeks. It's about 6% where patients get this Parkinson's type of symptoms, and 6% which is other, which is usually a problem with the cranial nerves. And this does vary across the study. So this is the study where patients have already received every other therapy possible. So the patients are a lot sicker going into it. Luckily, these side effects are a lot less when used earlier. At least that's what we see so far. But there is no free lunch. It is an amazing therapy, but there are some side effects to be aware of. This is the CARTITUDE-4 trial, which is looking at the 1 to 3 lines of therapy for patients who have relapse. And it's basically this CAR T product, cilta-cel, against just a standard of care, which could be dara with pomalidomide and dex, or pomalidomide with Velcade and dex. And again, you can see the CAR T group did far better than the standard treatment. You can see in the beginning, there's this initial drop-off in the CAR T curve of about 10 or 15%, and those are the same 10 to 15% of patients I talked about who, although they plan to get the CAR T, never actually get the CAR T infusion for one reason or another. Sometimes myeloma is too aggressive and you need to start a different treatment, things like that. So these things can happen. Yeah.
You mentioned the neurotoxicity from the CAR-T being a long-term effect. Are they finding things like Parkinson's tend to be permanent or long-term? Is it now that it's been around for some time? Is it that or is it one or the other?
Yeah. So for the CARTITUDE-1 study, for example, it was not found to be reversible and didn't really respond to typical Parkinson's medications. So in those cases, it was more permanent. In the earlier studies, the rate is probably a lot less than 6%. It's probably closer to like 1%. We still need more long-term follow-up data for sure, but there is this small but pretty serious long-term risk. So when thinking about the risks and benefits of CAR T and whether it's something that would be beneficial to you, you have to think of the positives, which are, it's a one-time treatment. So unlike effectively all the other myeloma treatments that we have right now, which are ongoing, continuous, you have to either take pills or come for injections every week or every couple of weeks. This is a one-time treatment. So it's one and done, couple-week hospitalization, and then no more myeloma treatment, hopefully for a long time, for several years. And this does give people flexibility to travel, to resume more normal activities, things like that. Just the caveat that there is still supportive care involved, so it's not like you can get the CAR T and just disappear for 3 years and then come back to the office. You do need, for example, antibody replacement, which is IVIG or subcutaneous IG. So that's to replace all the antibodies that you lost by killing all the normal plasma cells. And that can go on for a year or longer, sometimes 2 or 3 years. You do need to take some prophylactic antibiotics to prevent some of these serious infections. And you do need to have your blood counts monitored, and occasionally some patients need transfusions or growth factors to support the blood cell counts. Then on the downside, not everyone can get it for a variety of reasons. It's not really good for aggressive myeloma because of this 6 to 8 week period. So if your myeloma is going to be growing quite a lot in that time, chances are low that you'll actually get the CAR T infusion. So it might not be the best option. You do accept some risk of the inflammation, which can be severe in the beginning. And there's some small but very real long-term risks, like the neurologic toxicity, some second cancers, infections, and low blood counts. Any questions about CAR T before I move on? Are there age limits for CAR T? Not set in stone. It really depends on how fit someone is. Generally, probably not going to go too much higher than, let's say 80. And it's not just because of the toxicity, although that's a big factor. You don't want to expose someone to something that's going to cause more harm than good. But because of the bispecific antibodies, which I'll talk about next, which in my opinion are equally as effective, and they're much milder in toxicity. So I've had, I can say, patients over 90 getting bispecific antibodies and tolerating extremely well and having their myeloma go into remission. So for the bispecifics, it's a lot easier to say there's no age limit, anyone can get it. CAR T, because of its intensity, especially in the beginning, is probably not ideal for someone who's not that strong or fit. Any other CAR T questions?
Did you say that CAR T is going to be approved next year?
Yeah, I just remembered to repeat the question. So is CAR T going to be funded? Supposedly it's going to be funded sometime this year. But you never know. That's what they say. You never know.
Is that going to be tied to number of treatments that you go into, or?
It's going to be funded for, yeah, it's going to be funded for pretty much anyone who's had at least one treatment and is refractory to lenalidomide, to Revlimid. So it'll be available to really almost all myeloma patients after the first relapse, in theory.
So far only Princess Margaret is doing that?
It's not funded yet, so we're not doing it. Yeah. Yeah. Yeah, only Princess Margaret in the Toronto area.
Do you see any difference in the side effects based on what the number of line of treatment it is? Like if it's the fourth line of treatment or the 10th?
Yeah, so the main difference, are there any differences in side effects based on line of treatment? So CARTITUDE-1 had very heavily treated patients, so patients had like 5, 6 prior lines of therapy, sometimes up to 10. And the CARTITUDE-4 was just 1 to 3 prior lines. So looking at the 1 to 3 prior lines, there's a lot fewer side effects and less severity as well. So the inflammation, like the cytokine release syndrome, is a lot less severe. There's very few of the serious cases of that when you use it earlier. When you use it sort of as the very, very last line, patients have had a lot more other treatments. They may be sicker going into it. There may be a lot more myeloma that's poorly controlled. All of these can affect the side effects. So for sure, it looks like the side effects are worse if you use it very, very late in the game.
The CAR-T at Princess Margaret, is Princess Margaret actually doing the engineering on it?
Yeah, so is Princess Margaret actually doing the engineering of the CAR-Ts? No, for now it's all companies. We don't really have yet an academic CAR-T product in Canada. There's maybe some trials coming up in the future, but for now it's dependent on the company. So Cilta-Cell's Janssen, for example. We have some other clinical trials with different companies, but they do all of the manufacturing. We just collect the cells, send it over, they engineer it, and send it back.
Is there any work being done to minimize the time to 6 to 8 weeks and get it down to 3 weeks, 2 weeks?
Yeah, is there anything being done to minimize the time it takes to make the CAR-T? Certainly, not with this product so much because of the way it's made. You can maybe shorten it a little bit, but there's still going to be like the 6 to 8 weeks. There's some products that are still under investigation that can manufacture this in supposedly 48 hours, so just 2 days. There's some other products that are more like 1 to 3 weeks. So it's definitely, in a way, good. There's a lot of competition for this space, and hopefully we can get a product that's a lot shorter, and that way we can get it to patients without having to wait for 2 months.
So are there any clinical trials for the shorter period for those products that can do this quicker?
There are clinical trials, not in Canada that I'm aware of, but they're usually done at the institutions where they're developed, so maybe like Dana-Farber, which does the 48-hour one.
Generally speaking, would a STT transplant versus CAR-T, which would be more advisable for a patient over 70, all other things being equal?
For a patient over 70? It's hard to say. If someone's in, let's say, like early 70s in good shape, I still think transplant is a good option because you can always do the CAR-T later, potentially. CAR-T, like I said, there's not really an age limit. It's really how someone's doing physically. So in theory, we've given CAR-T to, for example, lymphoma patients up to age 80. Like I said, after that, probably the risks tend to be a little bit higher. And you might want to use a bispecific antibody, which I'll talk about, which is also extremely effective. But we do have, we're closing now, but we had a clinical trial of CAR-T versus transplant for newly diagnosed patients. That's usually under 70 though, most patients. So we still don't know like which is better in quotes. But for now, transplant, in every study that's been tested has beaten any approach not using transplant. So if anyone's in good enough shape to get a transplant, that's still what we recommend. Okay, so I'll move on to talk about what I think is a equally, if not more exciting, immunotherapy, which is bispecific antibodies. And basically what these are is, again, the Y-shaped antibody, and it has one arm that can grab onto myeloma cells, one arm that can grab onto the T cells, and just bring them together for a conversation. And the T cells come armed, and usually they kill the myeloma cells. So this doesn't require any engineering. It doesn't require you to send your blood elsewhere to be manufactured in the lab. These antibodies exist. We can get them just like any other drug, and you can give them to a patient quite easily when they need them, so you don't have to wait. And it basically just turns your own immune cells against the myeloma, and it's very effective, as I'll show. So there are a lot of bispecific antibodies. This is just a class of medications. There's a lot that you can do within this type of therapy. So you can go for different myeloma proteins, for example. The successful ones so far have been the BCMA protein, the GPRC5D protein, and the FCRH5 protein. So those are all in the myeloma cell. Hopefully we'll get other ones as well in the future. And for now, all the successful ones latch onto CD3, which is on T cells. And as you can see, there's very stiff competition among several different companies because of, how good these treatments are. Everyone wants a piece of the pie. And we'll talk about how well these work. So I think the titles are not on here. So this is a teclistamab, so it's the first one that was approved. It targets the BCMA protein. And you can see in this study, everyone got the bispecific. 63% of patients responded to the therapy. And the median PFS was about 11 months. But for the patients who actually responded and were in a very good response, it was well over 2 years. So the key here is really, there's basically two camps. You either respond or you don't respond, and if you respond, then you can tend to respond for quite a long time, usually over 2 years. This is another drug, elranatamab, which is very similar to teclistamab. Works the same way. Again, it worked in about 61% of patients, and the median PFS is about 17 months. But again, you can see even 3 years out, there's patients who are still in remission, doing quite well. So the question is, can we do better than 60%? Because you're going to say, well, how is this better than CAR T, which was 98%? And the thing is, you can't really compare across the different studies because patients who were on the CAR T study, as I mentioned, they didn't include the ones who didn't actually get the CAR T, so that's about a 15% drop. So really, the CAR T was about 85%. But generally, we tend to put patients who have slower growing myeloma and are less aggressive on the CAR T trials because we know they can make it for 2 months without getting a lot of treatment. Whereas the bispecific patients, we tend to put anyone who needs it, or at least that's what we did, onto those trials. So you have a pretty strong selection of more aggressive patients being put on the bispecific studies. So that's why some of the numbers might appear a bit lower. But can we do better than 60? We definitely can. We've learned a lot since these trials. We're looking at our own Princess Margaret data and going to publish this soon, but we've used teclistamab with 35 patients, and our response rate was 74%. But actually, if you look further, the ones that had a lot of myeloma really almost didn't respond to this therapy at all, just 2 out of 9 patients, 22%. Whereas the ones that had not a lot of myeloma, the response rate was almost 100%, it's 92. And if you look even further, the 2 people who didn't respond to this therapy, it was because they had already had a successful response to a different BCMA therapy before. So it's not like this was their first time getting this type of therapy, and it just didn't happen to work the second time. But basically, And we got pretty much 100% response rate if the amount of myeloma is low. And obviously you can't always choose, but with a lot of these patients, what we did was they had a lot of myeloma. We gave them chemotherapy first, so a bit more intense, aggressive approach, lowered the amount of myeloma, and then gave them the bispecific antibody, and in that case they responded. And this was the case, we had many people who, for example, were on clinical trials with bispecifics. They didn't respond because they had too much myeloma. We took them off the trial, gave them chemo, and then gave them the exact same bispecific through a different program, and then they responded. So we've learned a lot, which is that if you're going to send in your T cells against myeloma, you don't want it to look like this. That's not going to go well. So what you want is to get rid of as much myeloma as you can, even if you have to be aggressive, and then send in the T cells to clean up the rest.
How do you find the high-load myeloma?
Yeah, so in this study, it was anyone who needed blood transfusions in the couple of months before the teclistamab. That's probably an indicator that a lot of the bone marrow was taken up by myeloma, because we don't do routine bone marrow biopsies on most people, especially in relapse. But in the studies, it was, for example, if you had more than 50 or 60% of plasma cells, myeloma cells in the bone marrow, that was considered a less chance of responding to the therapy. If patients have masses outside of the bone marrow, so it's called extramedullary disease, so masses growing elsewhere, then those patients are a lot less likely to respond to these therapies. And if you have myeloma cells detectable in the blood where they're not supposed to be, they're only supposed to be in the bone marrow. Once they're in the blood, it's a little bit more aggressive. In those cases, it's pretty unlikely to respond to the treatment. So just using those three criteria, if you don't have any of those, then your chances of responding are extremely high. But this is a therapy that you want to start. If you know your myeloma is coming back, you don't want to wait a few months and just let it keep growing and then decide to pull the trigger. You want to do it a little bit earlier to give the immune system more of a fighting chance.
You said only 29 patients had been treated with teclistamab at Princess Margaret. Is that because of funding? Is that because it's not approved at all? I think you said those were clinical trials, and if it's because of approval and funding, when do you think it might be approved and funded?
Yeah, great question. So these are, first we've treated way more patients than this at Princess Margaret. These are the patients that we've treated once the drug became available outside of clinical trials, which was about 1.5 years ago. We're still waiting for the official funding, but the companies that make teclistamab and elranatamab, thank you, both provided free drugs basically for this whole time. So these are basically patients who got this sort of free drug from the company outside of clinical trials. So basically used in the same way as we would if it were funded. We're, again, expecting, in quotes, funding sometime this year, but we'll see.
For just teclistamab or separate?
For teclistamab and elranatamab as well. There's a couple of others that are also targeting BCMA that are still in clinical trials, but will probably be approved at some point. But you only really need one. I mean, there's some subtle differences between them. But
is there any evidence whether like GPRC5 have better results than the BCMA? Sorry,
I keep forgetting to repeat half the questions and getting stared at by Bob. But I'll address that on the next slides.
Okay.
Yeah. Okay, first I'll get into some of the side effects of the bispecifics, and then we'll talk about the GPRC5D. So this is just a side-by-side teclistamab and elranatamab, the two drugs that are approved, and just looking at some of the common toxicities. So looking at things like cytokine release syndrome, which was the severe inflammation that you can get from CAR T. Grade 3 and higher is the more severe range. So for CRS and for the neurologic toxicity, the ICANS, it's extremely, extremely rare for a patient to get this to a serious degree. So As you can see, only 0.6% in one of the studies, and that's it. So the inflammation is a lot milder than with CAR T, so it's a lot easier to tolerate in general. One difference is that infections were a lot higher than the CAR T study, with over half of patients getting a serious infection, landing them in the hospital. We'll talk about why that is. And there's no concerns really in these studies for the neurotoxicity, for example, that you see with CAR T or with second cancer. So the side effect profile is generally a lot more favorable with the bispecifics, except for this issue of infections, which I'll talk about right now. So what we showed is that when you use these bispecifics, you're not just killing the myeloma cells, you're killing the normal plasma cells. And your antibody levels, which are supposed to protect you from infection, all go to zero, and they stay at zero the entire time that you're on these therapies. And that wasn't exactly known while these clinical trials were being done, so patients weren't really getting any protection in that way. And what we showed and what others showed as well is that if you give IVIG, which is the antibody replacement, you can actually reduce these serious infections anywhere from 60 to 90%. And so really you can get rid of a huge chunk of what was the major side effect of these treatments. So why so many infections? Very few patients in these studies were getting IVIG or the subcutaneous version, which we're now giving routinely to all patients, and the infection rates are really substantially lower in more recent times. These trials also ran during the worst part of the COVID pandemic, and a lot of academic centers are located in major cities that had quite a lot of outbreaks. So this was 2020. It's a very difficult time. A lot of patients died from COVID in these studies or got very serious infections from COVID. Back then, there were no vaccines, there was no natural immunity, and there's no treatment for COVID. And now things are very different. Most people are vaccinated at this point or have had COVID, usually sometimes multiple times. So there's a lot of natural immunity. And if you're getting IVIG, for example, you're getting other people's COVID antibodies delivered to your bloodstream. So you do have some protection as well in that case. And if you do get COVID, we also have good COVID treatments, antiviral treatments. So extremely few patients at this point are dying from COVID while they're on the bispecific, whereas in the clinical trials, quite a high number, and kind of contributed to making these treatments look more dangerous than they are currently. There's no routine antibiotic prophylaxis at all. And there's a very low appreciation of the potency of this therapy early on. So now we take some measures to prevent infections that are extremely effective, and if you're on one of these bispecifics or have ever received one, you've probably been on all of these. But there's the IVIG, there's the usual shingles medication, acyclovir or valacyclovir. There's a specific type of pneumonia called PJP that you want to protect against, and this would be a medication like Septra or Tovicone or pentamidine. If you've had hepatitis B before, you have to take medication to make sure it doesn't come back. There's another virus called CMV that your doctor should monitor. And COVID-19, it's ideal if you get vaccinated beforehand because vaccines don't really work once you're on the treatment. And you should test yourself if you have any symptoms, because getting treated quickly is going to help you have a good outcome and avoid potential hospitalization, things like that. So moving on to the GPRC5D bispecific. So this is talquetamab. This is the key trial, and you can see here patients responded, again, about like 70% of the time, maybe a little bit higher than the others. And the median PFS was somewhere between 7.5 and 11 months, depending on which dose was used. So again, pretty similar results, I would say, to the other bispecifics. Because of the target, they have very, very different side effects. And one of the major advantages is that there are very few serious infections with this type of bispecific. So it's not that bispecifics give you infections, it's what the bispecific is killing that leads to the infections. In this case, you're just killing the myeloma cells, not the normal plasma cells, and so there's a lot fewer infections. That said, there are some unique toxicities. Patients get a change in taste, which can be unpleasant. Some patients can lose weight from this. because they just don't want to eat as much. There's some skin side effects like rash, peeling, things like that. That usually resolves after the first month or so. And then just cosmetic, but nails tend to break or become pretty brittle while on this treatment. There's another target, FcRH5. So this drug is, actually, let me take a step back. Talquetamab, despite being incredibly successful, was very surprisingly, I would say, rejected for funding in Canada. So we're not going to be able to get this drug routinely, at least for now that we know of. The company does have an access program, so they are able to provide the drug for free, but it's very time limited, just for the next few months. After that, we're not really sure what's going to happen. We have a lot of clinical trials looking at the same target, so hopefully we can get people on clinical trials, but it's a very disappointing decision to not have this drug funded. The last class of bispecific is the FcRH5. This is cevostamab. This is still only in clinical trials, probably still far away from being approved. And if they didn't approve talquetamab or fund talquetamab, I'm not sure they'll fund this one either, but it is quite effective, works about 60% of the time if you haven't had any prior BCMA therapy. If you have it, the amount that it works decreases a little bit, but I've had a lot of patients benefit from this as well. I'm going to go a little bit more quickly through the antibody-drug conjugate, belantamab. So there's a couple of very important studies, and we'll talk about the potential impact. But I guess let me stop and ask any questions about the bispecifics themselves.
I've been reading a little bit of literature that said people are looking at taking the bispecific and combining it with 2 or 3 other drugs, pomalidomide, I can't pronounce it, which is one of them, and they try to do these group things with it. Are we doing that, or because the side effects from some of those added drugs can be scary?
Yeah, great question. So the question is, are bispecifics being combined with other good myeloma drugs? And the answer is yes. We have a lot of these trials at Princess Margaret, and there's a lot more coming up as well. I think the key is really to get that response rate up from 60% closer to 100%, which is easy to do if you don't have a lot of myeloma. If you do have a lot of myeloma, you can either do a more aggressive approach, like giving intense chemotherapy, or you can try some of these combinations to avoid a lot of the side effects from the aggressive chemo. So these trials have been pretty successful so far. Combinations with like daratumumab, for example, is very effective. Pomalidomide, also very effective. And there are some coming up I'll talk about as well. But certainly they're very easy to combine because the side effects from the bispecifics are, especially after the first couple of weeks, really minimal. It's just the infection risk, which can be mostly mitigated. So they're a lot easier to combine than like CAR T, for example.
When you refer to intense chemo, are you referring to melphalan?
So the question is, when I say aggressive or intense chemo, am I referring to melphalan? Sometimes if someone has stem cells left over and they're in pretty good shape, yes, you can do that and kind of try to reset things. If you don't have stem cells or you don't want to be quite as aggressive, there's chemotherapy regimens like DPACE, for example. It's a combination of dexamethasone plus 4 other chemos. And for this one, you don't need stem cells, and the doses can be adjusted for the person's age, their fitness, their blood counts, their kidney function, all that stuff. So you try to find a good dose that's going to kill enough of the myeloma. Patients take, anywhere from 2 to 4 weeks to recover from that, and then you can start the bispecific after.
Can you tell us a little bit more about how these are being this bispecifics in terms of dose and schedule?
So the question is, can you tell me more about bispecific dose and schedule and how it's given? Yeah, so most of them are subcutaneous, so they're shots under the skin. There are a couple that are still intravenous. For now, the step-up dosing, which is in the beginning, is we give like a baby dose, then a medium dose, and then a full dose. That's similar to the CAR T, where you have to be monitored closely for the first week or two. After that, it's just weekly subcutaneous injections. The studies were done this way, giving the drug every week, kind of indefinitely, sometimes spacing it out to every 2 weeks. But what we found is once you get a really good response and you don't see any more myeloma, you don't really need very intense treatment, and you can probably space it out to just once a month, kind of like maintenance therapy. It's not proven yet, but it's basically like that.
But that still has to be the institution cost, and you can administer it yourself.
The question is, can the institution, can you administer it yourself? No, not yet. Yeah. But usually once you get a response, you can go down to once a month, and sometimes you can even stop. And there's been patients on the clinical trials who, they had some kind of side effects, and they had to stop 3 or 4 months into the trial, and they're still in remission like a 1.5 years later. So it's not even clear that there's an advantage to continuing to give the therapy over and over once you've killed everything you can kill with this therapy. So
The reason I'm asking this, okay, can you travel?
yeah, of course you can travel, yeah. We want our patients to have good quality of life, so we always try to arrange it so we give the least amount of therapy and while still controlling the myeloma. With the bispecifics, once you get a response in the first 2 or 3 months, you can probably go down to once a month and not lose any of the efficacy. Probably better safety, fewer infections if you do it that way. And then, yeah, in that whole month you can travel, you can do whatever you want.
You mentioned about funding being an issue. Is it normally through the federal or the provincial government or some combination?
So my understanding I've gained from being here for a couple of years is first it gets Health Canada approved. That just means the therapy is effective and safe. That's all it means. It doesn't mean it's going to get funded. It then goes through a review by the Canadian Drug Agency, the CDA, and that's a national organization. And they look at things like health economics, how much it costs, how much the actual benefit is, what the side effects are, things like that. Then based on all of that, they make a recommendation on whether the drug should be funded or not. And then each province will decide individually whether to fund it or not. Usually, they mostly follow the CDA recommendation, but that's basically the basic steps on how it works. So talquetamab, for example, is approved by Health Canada, but then rejected by the CDA at that next step.
And paid for by the provincial government.
Sorry?
Would the cost of it be paid by the provincial government?
Yeah, the provinces eventually pay for the drug once it's funded. Each province's plan will, they'll list the drug at a certain price and then they'll pay. Okay, so we'll go quickly through belantamab, which is an antibody-drug conjugate. All this means is that you have an antibody, but rather than being like a bispecific where it grabs onto a T cell and a myeloma cell, this only has proteins that identify the myeloma cells. The difference is that they carry a little bit of chemo on them attached, so that when they identify the myeloma cells, then it triggers them to release the chemo and just kill what's in the vicinity, which is usually just the myeloma. It's a bit of a different approach. It doesn't directly involve the T cells like the bispecifics or CAR T. There are a couple of big studies. I'll just go through them quickly because we already covered a lot of information today. So there are 2 big studies that just came out, DREAM7 and DREAM8. DREAM7 was comparing this belantamab drug with Velcade and Dex versus daratumumab, Velcade and Dex for patients who had relapse. And long story short is belantamab did way, way better than the daratumumab treatment. DVD is not it was a standard of care when this was designed. It's no longer the usual treatment that we would give for this situation, so it's hard to compare, but the outcomes were pretty good. And then the other trial is belantamab with pomalidomide and Dex versus pomalidomide, Velcade, and Dex, so looking at a different combination. And again, the belantamab combination did a lot better than the so-called standard treatment. This drug has a lot of eye toxicity, which people don't like to hear about or experience, which is you can get like blurry vision, like dry eyes, things like that, and sometimes a decrease in the visual acuity. Usually not to a severe level where you're like legally blind or anything like that, but everyone who's on the drug for long enough will be affected by this eye toxicity, so that has to be watched closely, and usually the only way to treat it is it's reversible, but you just have to wait and not give the next treatment for a while. So sometimes patients go 3-4 months in between doses because they're just waiting for their eyes to recover. There are some targeted therapies, so for patients who have translocation 11-14, there's about 20% of myeloma patients. This abnormality is extremely sensitive to a class of drugs called BCL2 inhibitors, which are venetoclax and experimental drugs, sonrotoclax. So these therapies are not approved anywhere for myeloma, yet at least, but they're extremely effective, we know from clinical trials, and these may be available through access programs provided for free by the companies or through clinical trials like we have one at Princess Margaret. And this is a really good option if you have this translocation because the biology of your myeloma is a little bit different, so we need to use a slightly different approach. And usually these are combined with something like bortezomib or carfilzomib. Okay, so I've covered a lot. This is the algorithm and some of the changes that are coming in red, which is the quadruplet therapies we talked about in the beginning. We're going to have some more options like the belantamab option, cilta-cel for the earlier relapse, and we're still going to have a lot of clinical trials for new treatments. And myeloma in some ways is like swinging through the jungle, like you're Tarzan, and always looking for that next vine to grab. As of now, we haven't been able to truly cure myeloma, except maybe in a minority of patients, because these cells are so hardy, so they do come back, usually after a long period of time, hopefully. But the goal is always to get to that next treatment, and then the next one, and the next one. And if you do that long enough, then you give time for more treatments to be developed. For example, if you live long enough to get to here, then you're able to see the development of the immunotherapies, for example, that can give you another few years and another few years and things like that. So the goal is always to find new treatments that are effective and can keep people going for as long as possible. So what's in the pipeline? So we have a lot of clinical trials at Princess Margaret. We have, for example, CAR-T product targeting GPRC5D. We have some trials with mezigdomide, which is a new drug I haven't talked about, but it's basically like a very strong version of lenalidomide or pomalidomide. We have a different way of targeting the GPRC5D protein with a new antibody. We have combinations of bispecific antibodies with other myeloma drugs. We have trials specifically for patients with, for example, translocation 11-14. And we'll be having a trial later this year of intravenous curcumin, which many of you may have heard of turmeric or curcumin for myeloma and may even be taking supplements. Unfortunately, it's not, even though it's extremely effective in the lab against myeloma cells, it's not easily absorbed at all. In fact, most of what you take in is not absorbed, so you would have to take really large doses to have any effect against the myeloma. But we're working with a company that has an intravenous product that bypasses all of that and can get a higher dose of curcumin right to the patient. And we also have not just trials at Princess Margaret, but across Canada as well, through our Canadian Myeloma Research Group. For example, we have trials for newly diagnosed patients, again with sort of newer or stronger drugs. We have a bispecific combination trials that are coming up, including one that I'm starting up that hopefully will be on be up and running later this year. But we have a lot of exciting things, not just locally at Princess Margaret, but across Canada. As Bob Dylan once said, the times they are changing, and there's a lot of upheaval, both in the myeloma world and in the world in general. But things do change really fast in myeloma, The next question is obviously, how can we keep up? We already saw, for example, talquetamab being declined funding, which was very surprising. It's probably not going to happen in many other countries, so there's just some things we have to do as a country to try to stay ahead. So there's a few issues. First, treatments are getting increasingly complex and resource intensive. For example, like the CAR-Ts or bispecifics, where you have to be in the hospital for 2 weeks, you have to be watched very closely. It requires a lot of resources from the institution to be able to give CAR-T, which is why right now Princess Margaret is the only one that can do it in this whole area. At the same time, people are living longer, which is fantastic, but requiring more care. So there's more and more patients who need chemo, who need time in the chemo suite, who need all these resources to see the doctors, to get blood work, imaging, all this stuff. So it's a bit of a crunch on that side. Canada as a country is, I found, very slow to fund even very effective therapies, and sometimes not funded at all. And it's a double-edged sword of the public healthcare system. In the US, it's basically funded right away, but there's a million other issues with the healthcare there. So it's always a compromise, but in general, we have a lot of exciting myeloma therapies, but we don't necessarily know when they're going to be available for everyone. And so I would say clinical trials are really essential to get patients access to the most cutting-edge and effective therapies. And this is because clinical trials are all paid for by companies, and sometimes you can get drugs that we already know are effective, but they're just not available. And sometimes you can get treatments that are more experimental that might have a chance of working as well. So I would say we really have to work together as a community to really get access to the best treatments for everybody. And there's a couple of ways to do this from my point of view. One is through the Princess Margaret Foundation, and the other is through the Canadian Myeloma Research Group. So I'll just talk a little bit about both of those. As I mentioned, we have a really large myeloma program at Princess Margaret. We're actually one of the biggest in North America and in the world. We see over 400 patients, new patients every year from Canada, from Ontario, other provinces sometimes, and internationally as well. We have over 70 research studies open, giving people access to therapies before they become available. And for example, in 2023, we had 300 patients enrolled on our studies. We have 1,000 patients in follow-up, so a really large program. But all this runs not through government funding or anything like that, as you would expect, but actually a lot of it comes from philanthropy. And so a lot of you may be familiar with the MM5K walk. So this is going to take place in June this year on a nice Sunday morning. Really nice event for everyone to get out with their families and support the community. Many of you are already very heavily involved with this. And I'll just say that through this walk and through the foundation, raised $10 million over the last 20 years, which is really a lot of money. And I'll show you exactly what that money did. But in case you haven't registered already, feel free to register, look it up, and really hope to see everyone there. But obviously the question is, where does the money actually go? And I'll just highlight a few points. So first, the money is used to recruit some top doctors from around the world. Some of you may have known Roger Tiedemann, who was recruited to Princess Margaret with help of his foundation money. And we also train the next generation of fellows. So these are the next generation of myeloma doctors that are going to disperse around Canada and be treating all of you. And sometimes they go back home and spread the knowledge there as well. We use the money to provide clinical services that wouldn't otherwise be available, so we can try to go above just the bare bones services. So for example, if you've had a bone marrow biopsy at Princess Margaret under conscious sedation, or if you've interacted with our nurse practitioners, for example, in the MHDU, this is all funded through philanthropy. The money goes to support the Princess Margaret database, myeloma database, which is linked with the national database. And I'll talk a little bit more about that when I talk about CMRG. But we have over 10,000 patients in this database at the moment. And I think most importantly, the money goes to support our research program to be able to keep the lights on, keep all these clinical trials open, keep all these therapies accessible to patients. And Princess Margaret has been involved in pretty much all the important clinical trials in the past decade, and it's led to 14 different drugs being approved for myeloma. And of course, we want to keep doing this and keep providing access as much as we can and try to fill in the gaps left by lack of funding. And I would say this whole success of Princess Margaret and the international reputation, all of that, the success of the trials program, is really not possible without this support. It would look very different if we didn't have this. I want to talk about the Canadian Myeloma Research Group as well, which some of you may be less familiar with. This is a national organization comprising all the important academic centers across Canada, and all the doctors that treat and research myeloma are part of this network. It's founded less than a decade ago, but it's already had a really tremendous impact across Canada. And if Donna saw this picture, she would be a little bit embarrassed, but yeah.
I just point out that Dr. Donna Reese is coming to speak to us at our next in-person meeting on June 7th.
That's fantastic. So Jan mentioned Donna Reese herself is coming to talk to you guys about CMRG, and I think it's a tremendous opportunity, and I hope everyone can attend. But I'm going to embarrass Donna for a second by putting her picture nice and big. Those of you who have been lucky to know her or to be her patient already know all of this, but she's really an incredible lady. She founded the whole CMRG from scratch a decade ago, built it up from the ground, runs a very tight ship with a very small crew and really a shoestring budget. But through all of that and her dedication, has really made this into a prestigious international myeloma group that's recognized around the world. And, you know, CMRG has a few important points to focus on. So the main things that this group does is, one is to allow clinical trials to be performed across Canada. So this is a platform where we can design our own trials that are applicable to our patient population that might be different than, let's say, like industry will design a clinical trial. They're going to design it with the US in mind because that's the biggest market. And they're going to design it based on what myeloma patients in the US look like. What we do at CMRG is design trials that are specific for Canadian patients and the needs that we have. So that's a very important point, and I'll talk about some of those trials. Real-world evidence is extremely important with our database to identify sort of gaps in our research and to advocate for funding of new drugs, which has already been done. And translational research I'll talk about as well. But as I mentioned, it's basically an umbrella organization. We try to involve patients at every level in our committees. Donna will talk more in detail about this, but they have monthly webinars as well, physician seminars, and advocacy is an important component as well, including giving feedback to the funding bodies. And sometimes they listen to us, sometimes they don't, but we try at least. So what has CMRG actually achieved? Why is this an important organization? In the last just 10 years, we've run 10 clinical trials across Canada with over 500 patients enrolled. And these are all patients who got treatments that they would not otherwise have gotten access to because of all the work done by Donna and the CMRG. Our national database, as I mentioned, has over 10,000 patients. And the reason it's important is because when new drugs come up for funding, they need to know the benchmarks, and they need to know how are myeloma patients doing without these treatments. And if we don't have evidence to show that, then they'll just say there's no evidence, and it'll be a reason to, an excuse to decline the funding. So we're here to provide the evidence of what's actually needed in Canada. And so far, it's been an extremely productive database. We have 17 publications already. There's 13 more projects that are in development that are going to be published. I have several projects through here myself, and it's really an incredible platform for researchers across Canada to help answer important questions. And lastly, CMRG is developing a national biobank, which is basically a place to store specimens for laboratory research to support researchers across Canada. And I think more than ever, to help develop these homegrown technologies so we can develop technologies in Canada, test them on specimens here, and not be reliant, especially now in any other country, for research or for technology, and all that. So I think overall, extremely important tenets that CMRG has. I think it's been extremely successful. It's still a relatively young organization, less than 10 years old. But thanks to Donna's dedication, she's now retired from clinical practice, as you guys know. But she's still very, very busy running the CMRG, and she's not planning to stop anytime soon. So if you're interested, you can go more to the website to learn about the organization and what's been done. And if you want to contribute, that's fantastic. Money is tight as always, and we want to keep all these initiatives going to help really benefit all of you guys. So thank you so much for listening.
We're really beyond time. If there's maybe 2 questions that he can answer very quickly. Rosa?
Yeah. With the tariffs coming from the U.S. government, do you need to be concerned about any of having access to the cancer medications that possibly come from the U.S. to Canada? Because, for instance, I use Nemlaro, and it happens to be a Japanese company based out of Japan. But I'm wondering about myeloma cancer medications in general. Will the tariffs or will they affect access? Am I giving you a clear question?
Yeah, the question is, are the tariffs going to affect potentially access to medications, especially coming from the US? I have no idea. I'm not a political prognosticator. It is a very chaotic environment. We haven't really seen any disruption yet to any of that. And I think, when you think about how much cancer medications cost and the benefit for the companies to actually get them here, my guess is they would probably eat some of the cost. It's still, these drugs cost several $100,000s a year. So there's still a lot of profit to be made. And in this case, I hope it's a good thing that motivates them to continue providing these drugs. So I haven't heard anything, but this is going to be on video and going to look wrong in a few months.
It's the pharmaceutical companies that are distributing the medications, not the government. So they're the ones in charge, I would imagine.
Yeah, so the companies are in charge of everything to do with the medications. The government just pays for it. It's a little bit different with a different therapy, like the IVIG I talked about, for example. All of that is sourced through the Canadian Blood Services, and they have to basically get all the product from the US because we don't have the manufacturing in Canada to be able to make that very important product. So that's something that could potentially be affected. We don't really know yet, but yeah, I think there's a lot of unknowns. I'm definitely not the right person to answer this question.
One more in the back.
I don't know if you can answer this one or not, but given the negative climate in the U.S. for universities and researchers, and what Elon Musk is doing, do you see a slowdown in university research for cancer and myeloma, given other cancers also relate to myeloma, some of the discoveries that will help us? Do you see a slowdown at all?
Okay, so the question is, do I see a slowdown in myeloma research because of, in the US, because of cuts to the government? Again, I can't say for sure. I think without getting political, there's been a lot of slashing of pretty important federal departments, like NIH, for example, that provides a lot of the research funding. So a lot of researchers that are getting money from these institutions to conduct their research probably might suffer from lack of funding in some way in the future. I don't know for sure. I would say research in myeloma is a combination of pharmaceutical industry research and academic research. Academic usually lays the groundwork for a lot of the drugs that come later, so it is extremely important to have that funding available. I think. Yeah, I hope they all come here. Yeah. But yeah, I think the national research funding might be an issue in the U.S. I'm not really sure. Pharmaceutical companies do a lot of the R&D for these drugs, so hopefully that's less affected. But yeah, I'm not really sure. I think, impossible question to answer about the impact, but.
Yeah, so can I share your mic?
Sure, of course.
So it is my great pleasure to thank you today for being here and for all you do. And I had this whole long story prepared, which I won't put you through because, we ran out of time. But I do want to let you know Dr. Lancman is also my doctor. And, you already saw his level of compassion and care when he opened up his presentation with Dave McMullen, on the picture, and then gave all the praises to Donna Rees. And I have to give a lot of praise to him now. We had a very, very simple start. I had Dr. Tiedemann, and then, Dr. Lancman arrived, and we had a very easy time in the beginning. I was in remission, and then things got to be very, very tough. And this last one was really the hardest round. And I'm not going to go into detail, but I want to tell you, he had to take that look at me, and he said, we can make you feel comfortable, or we can maybe try one more thing. And this one more thing sounded quite intense. And I did ask the question, Dr. Lancman, do you really think it's worth me putting myself through all of this? And I'm tough. Am I tough? I'm very tough. I said, is it worth putting myself through all of this? And he looked at me and he said, Suzanne, he said, I wouldn't suggest it if I didn't think it was possible. But we are, my husband, Dr. Lancman, and I, we are in a very, very, very tight spot. A lot of things have to fall into place. And all I can say, it was nothing short of a miracle, and I'm now on the other side of it. And this is, like Dr. Lancman said, it takes a team, and it takes donations, and it takes people who care and who are dedicated to make all of this happen. So, of course, I'm so grateful to be able to thank you personally, but on behalf of the entire multiple myeloma community, thank you for taking the time, and thank you for this incredible presentation. I know it was full of information, but for somebody like myself, it was really, really, really very important. So thank you very, very much, and I'm looking forward to many more hat tricks.